Welcome, Dr. Visser.
Sure.
So Dr. Visser has been a Chief Medical Information Officer and is currently serving as professor at University of Erasmus in Rotterdam. He has pioneered multiple AI adoption projects and has also been a leading voice in health tech in current scenarios. So Dr. Visser has been a good friend and is also one of the voices that is one of the most tech-savvy radiologists that we have come across. So Dr. Visser, thank you for joining us, and thank you for agreeing to talk about making AI real. So let's start with talking about why AI isn't real today, right? I mean, what are the challenges? What are the challenges that we need to take upon so that we can make AI more real and more conducive to the current workflows of doctors?
So I think one of the main current issues is trust, right? We need to make sure that we can trust the AI models. So that's why we need not only internal, but also external validation of the different available AI models. That's one thing. The other thing is that we need a seamless integration into the workflow, that you really allow the radiologist using the AI tool as easy as possible. And last but not least, you should also aim for a business case, and not only aiming for quality, but also for quantity, right? Efficiency gains, because otherwise there won't be any money available to be freed up to buy the AI solution.
Right. So thank you, Dr. Visser. Let's understand that a bit deeper with a couple of examples, starting with lung cancer, right? Early detection for lung cancer is one of the major issues that we are facing, right? Most of the cancers are being detected in stage 3 and 4. So do you see a role that AI can play in doing some stage shift around early detection of lung cancer?
Sure. And I think there will be two main streams for making the stage shift happen in lung cancer. So the one thing, of course, is to start with a lung screening program. And there will be a lot of CT tests available to be read by radiologists, and that radiologists aren't available. So that's why you need an AI solution to support the radiologist in reading those CTs. But it's not only the screening part, it will be also the so-called incidental pulmonary nodules. So there will be a lot of CT scans having those nodules available. Using AI will increase the detection and also contribute to the stage shift that we need in lung cancer.
Right. So detection is one part of the problem. The next problem is a lot of these patients are called back for repeated chest CTs, right? And tracking progression. How do you see AI helping in tracking progression for these lung nodules and helping assess what kind of malignancy risk can be associated with them?
So it's important to have the right information available when tracking a lesion, right? So think about timelines, but also think about malignancy rates, malignancy scores, so that you are able to assess what is the probability that this particular nodule will develop into lung cancer.
Right, right. So we talked about the problems in current lung cancer screening programs, and we also sort of talked about what kind of role can it play in detection of nodules. So considering all of it, how would you envision a lung cancer screening program where AI is being used successfully? Like, what does a successful implementation of AI in lung cancer screening look like?
So I think in general, and I was also referring to a talk that we had this morning on the future of medicine, talking about screening, we need to identify the high-risk individuals. So when thinking about AI and CT chest imaging, we should also be able to identify those at a higher risk to develop lung cancer. And we know that specific chest findings like emphysema do have a higher probability of lung cancer. So we should be able to identify those cases. That's one thing. And the other thing that's related to that is to come up with a comprehensive solution. because nodule is only one part of the patient, the test the patient. We also need the other pathologies being detected by the AI to come up with a full interpretation of the test.
Yeah. So you made a very good point about other pathologies coming into apart from lung nodules, right? But in a screening program, we also have to take care of other clinicians apart from radiologists, like pulmonologists, oncologists, who play a collaborative role in running that screening program successfully. So do you think like just having an AI algorithm would suffice, or do you think like, there is a more broader software tool required which can enable seamless collaboration between these clinicians? What's your viewpoints on that?
Yeah, absolutely. So in general, I think the advantages will be downstream of radiology, right? So that's important also to consider when thinking about the business case. That's one thing. The other thing is that we shouldn't be talking about radiology alone.
Right.
Radiology is only one piece of the puzzle. We are aiming to get to the diagnosis.
Yeah.
So we should aim for integrated diagnostics and making sure that you can combine and integrate the different pieces from the puzzle, different pieces of information from the different diagnostic specialties, and then we are facilitating the diagnosis, come up with an appropriate screening and give the information so that the referring physician, so that he can start or she the right therapy.
Right, makes sense. I think let's take another example for MSK X-ray, say for example. But before we do that, are there any questions around lung cancer and usage of AI in lung cancer? Feel free to shoot them.
I have one.
Yeah. Okay.
So, how do you address the bias of AI? What do I mean by that is, say that AI is already in the workflow. The radiologist is reading X-rays, and after like maybe 6 months, he's very comfortable with AI. He almost made friends with AI, that he's accepting AI in his workflow. But at the end of the day, we know that AI also will have false negatives. It means that a module which was supposed to be caught by the AI was missed by the AI. What if the radiologist literally trusts the AI and just skips it? How do we address such situations?
So I think there's two important things. So one thing is we have to teach the radiologist in the right way, teaching about the false positives and the false negatives. So if you know that the accuracy, the sensitivity is lower in a specific area of the lung, you should make sure that the radiologist have a careful look at that particular area. So teaching the radiologist is very important. The second thing is we have to find a way to monitor the AI performance over time, because by nature the performance of a model goes down. So in collaboration with the vendor, we have to find a way to keep the performance high, to even improve it, to avoid damage to the patient.
Right. So taking the second example of musculoskeletal X-rays, right? One of the questions that we have been hearing is about what is the need for AI to detect fractures, right? Doctors can already detect it, all of these signs of fractures or abnormalities in bone X-rays. So what would be your take on that? Is there a case for AI in MSK X-rays, and what is that case?
So I think twofold. If we first have a look at a radiologist, there can be subtle fractures, right?
Right.
A lot of fractures we can't see, but there are subtle fractures, and it could help in detecting those fractures. The other thing is that there is an increasing amount of patients in the emergency room. So radiologists do not always have time to have a look at all those individual images. And the emergency physician do have a look at it by themselves, but their interpretation skills are not that good.
Yeah.
So then it's a special case where the AI can help the emergency physician in assisting the interpretation.
Yeah. So the next question that we get usually is the doctor at the end of the day has to sign that radiology report, right? Then what value does AI add on top of it? They still have to see that image and sign that report. So do you see any efficiency value added in terms of using AI for MSK X-rays?
yes, but then I'm also thinking of, a lot of current AI is narrow. It's only looking at fractures, only looking at nodules. But I think we should aim for a more comprehensive solution, right? Because a radiologist, of course, is looking for the fracture, but he also looks for a tumor, for some soft tissue lesion, for whatever. So developing AI tools that are comprehensive, that would definitely be a positive for
Makes sense. So I would go back to my same question as lung cancer screening programs, right? What would a successful implementation of MSK AI in emergency departments look like? I mean, given your experience of adoption of AI, you have adopted multiple algorithms and you have pioneered this field. So how do you look at a successful implementation of AI algorithm in MSK X-rays?
So when we talk about a valuable implementation of AI in the emergency room, the emergency department, I think it's important to consider the chain, so the healthcare chain, right? So a patient presents with a fracture, and what does that mean? So we have to involve the emergency physicians to talk about the workflow in detail. Right. What information will become available at what point of care, and then make sure that the relevant AI information, so the output generated by the AI, is available at the point of care. Right. For the right physician, so that it can basically assist workflow.
Got it. You made a very good point about building comprehensive AI, right? The MSK AI situation currently is that a lot of algorithms stop at detecting fractures. So what would your vision of a comprehensive MSK AI solution look like? What else can be built upon MSK X-rays in terms of AI solutions that will actually add value to patient care?
Right. So it's important to mention that MSK X-rays, it's not only about fractures, right? Right. A lot of X-rays are made for osteoarthritis, right, and for prosthesis, right. And then I'm coming to my next point that a lot of X-rays are also follow-up. Right. So if you are able to compare images, that definitely will help. Right. So to compare if there is a natural course of healing in the fracture, or detect any displacement or dislocation of the fracture. And also if osteoarthritis progresses over time, or regarding a prosthesis, if there is any change in alignment, for example. Right. So comparison with former examinations, that would also be very helpful for MSK X-rays.
Right. So basically, I mean, it seems like progression monitoring, like lung nodules, would be a use case in MSK AI as well, like monitoring.
Yeah, absolutely.
Cool. Makes sense. I think that's all that I had to discuss on MSK X-rays. But is there any question on? Yeah, sure. Go ahead.
I'm just curious. A lot of decisions being made by other specialists from the radiology. So how is the perception changes when they know that the AI has been used by radiology? Do they trust more because they use it in their file, or do they have their own apprehensions?
So I think the important thing is that who is responsible for the interpretation. And I think, at least for now, it should be the radiologist, it should be the doctor, but really those who are making the report. It can be assisted by AI, but it's an augmentation, right? So if the referring physician knows that the radiologist is being assisted by AI, it can even increase the trust in their report. But you have to make sure that the false negatives and the false positives, so the weaknesses of the algorithms, are being addressed and covered by the radiologist.
One last question.
I recognize my questions for you and as well. One of the challenges to make AI is the long regulatory process that companies have to provide the evidence to the regulators. my question is, how can you basic this process where the industry, the university, hospitals, property specialists like you can come together and basic this process? Any ideas on how you can basic the regulatory process and the evidence generation?
So I think a close collaboration with industry and academia, that is very important. And not only for the regulatory process, also to generate clinical evidence.
Yeah.
Because for you as a company, it's of course very important to get the regulatory approval.
Yeah.
But for me being a doctor, it's about the added value of the patient. How are we going to improve the clinically relevant endpoints?
Yeah.
And how are we going to investigate those before deciding on implementation of the AI?
Yeah. I think lastly, I would like to end on a perennial old question. Making AI real, you have already made a lot of AI algorithms real, and I'm sure you're going to make tons of AI algorithms real. But one of the questions has been like, if AI becomes real and AI algorithm becomes real, is it going to replace radiologists? That's the perennial old question about a fear of AI replacing radiologists. What's your take on that?
So my take on replacing radiologists by AI, at least for now, and it's hard to predict the future, but at least for now and up to 5 to 10 years, there will be an augmentation of the radiologists.
Right.
So the AI will assist the radiologists in reporting. You can compare it with the self-driving car, right?
Right. Yeah.
Still, the driver is in the seat and, basically responsible for the drive. Yeah. I see the same role for the radiologist. How it will end up eventually,
Or pilots. I mean, pilots flying the planes, right?
Yeah.
I mean, the hardest problems, which is the landing and the takeoff, are still being done by pilots.
Right.
So AI is good at the boring and the boring to do stuff. Yeah. So that's all from our end. Thanks a lot, Dr. Visser, for stopping by and having a chat with us. It was a pleasure to host you, and looking forward to more collaborations with you.
It was a pleasure, and looking forward.
Yeah. Thank you.